This is a case of a 33-year-old woman who had right ear pain and worsening lesions on the left shin. She had a remote history of GPA dating back a number of years. And I'm going to kind of cut through this. She had relatively mild disease or limited disease, had arthralgias, but had a problem with hearing loss on the left side. She was known to be C-ANCA positive, confirmed by PR3 analysis. She was started on prednisone 40 milligrams and mycophenolate. So it was this is kind of reading between the lines here, being treated as a limited disease, and this goes back away before we had trials of mycophenolate versus azathioprine, but whatever. She did well with the hearing, but stopped the mycophenolate because of potential for side effects, and remained on and off largely because of recurrent skin lesions, which I'll show you in a second. More recently, she now presents with right-sided ear pressure and pain. This had been managed in the community and seeing physicians treated with multiple courses of antibiotics without improvement. This is what happens when there's lack of follow-up. Seen by ENT, had a tympanoplasty, but these skin lesions, which had been recurrent, were also worsening over the past several months. Physical exam was relatively unremarkable except for the tympanic membrane and the purulence. Joints and musculoskeletal exam was okay. She had a CT scan of the chest which showed no clear-cut evidence, some tiny nodules of indeterminate significance, no active urinary sediment. Was known to have a lot of sinus disease and had these painful lesions for a number of weeks, which had come and gone, but these were flaring up and giving her a lot of problem. So this peculiar kind of skin lesion here to begin with. So topically, just to throw out to you, the dermatologists on the panel here, what does this bring to your mind, and what kind of concerns?
The appearance actually, to me, looks like a neutrophilic dermatosis, or resembles a PG or pyoderma gangrenosum type lesion.
The overhanging borders and the purplish kind of thing. Mm-hmm. Tony, you down by that?
Yeah, that's exactly what I was thinking. I mean, I think this needs to be biopsied in the appropriate areas.
Okay, Neil?
Well, I was thinking about factitial, actually. It looks pretty damn symmetric.
It's pretty weird, isn't it? Be that as it may. I thought the same thing. So this is the biopsy of the skin. I apologize, I don't have the pathology to show you, but there was evidence of true vasculitis noted, and there were granulomatous features, and there was an enriched infiltrate that included a mixed inflammatory infiltrate with neutrophils, lymphocytes, and histiocytes. And this was the descriptor of this lesion. So now you have a patient with hearing loss, draining ear, packed in sinuses, and this skin lesion. So you would now consider starting this patient on steroids, pulse steroids, followed by high-dose oral steroids, high-dose oral therapy followed by methotrexate, high-dose oral therapy followed by rituximab, high-dose oral therapy followed by cyclophosphamide, or beg your rheumatologist to come into the hospital and deal with this. So we'll take a vote here at this juncture. Audience response. And then we'll get your take on this as we go along. So, all right. So, before we, well, since Well, that came out pretty good. So you can do whatever you want, actually, in this, according to this audience. So, Neil, why don't you want to start out with what your kind of thinking is?
I just wanted you to help the dermatologists in the room, including this one, about what's going on in the ear.
Yes. And that's very important, and I'll show you some, and obviously this is a case report, so my major consideration in this would be, there's hearing loss, and the question is this just conductive because of this packed-in sinus and drainage, or is there something more pernicious because she's had a history of ear pain on the contralateral side. This patient needs to be imaged for infiltrative disease, and that's coming along the pike.
The hearing loss is a finding associated with GPA, correct?
It can absolutely. Carol, you want to comment to what you would be thinking just off the bat with with that presentation and problem, where your thinking would be going?
Yeah, so I think that it would be important in this setting as far as to get imaging, as far as where you're seeing the temporal area, where you're looking at the mastoid sinus, the middle ear, and certainly getting a very clear ENT assessment as far as what there is present. But certainly it could fit in this picture as far as it's a little unusual to not have other ear, nose, and throat, sinus manifestations that are active at that point. But we can see isolated mastoid and otic manifestations that can occur.
Now, I know what's going on here, but I would have had a consideration also just knowing that there was hearing loss on the other side remotely, and now it's on this side of some type of basilar infiltrative process. So and I'm influenced by what's going on here. So she had this ear drained because it was a bulging disc, and there is compression, and there is some element of obstructive disease, and was started on prednisone and rituximab. I think that I'll show you a little bit going along. So after the first infusion, now note, this is the dosing regimen of weekly rituximab that would be given over a 4-week period, and this is not very much prednisone. And this was started, and then within the week, comes back in with worsening right ear pain, and now has a facial droop. So now has another nerve involved. I think we've actually, for sake of time, our suspicion was that we would have probably imaged this right off the bat centrally, but this patient is headed to that. Now, at the end of that week, she's back in the hospital because of severe pain, and now having right-sided eye pain associated with photophobia, diplopia, and ptosis, and severe tenderness around the right eye. Carol, would you like to comment about that?
Yeah, so what you can see as far as in this picture is she's now developing features that look like they're clipping other cranial nerves. So with the fact that, again, you have the ear involved, you start to think as far as what's going on as far as the pachymeninges and as far as if there's a process that could be affecting with that.
Okay. This patient is imaged, and these stir images here show this very prominent leptomeningitis, actually pachymeningitis, is an infiltrative process. To us, this means that there is a prominent granulomatous process going along, as well as the angiocentric process that was going along in the skin. So this is no longer limited disease. This is involving the brain, and this is serious business. But remember, she's only been into this therapy for a week, but now things are not going well. And this is what the skin is looking like. And I don't know exactly the chronology of this, but it's not looking good here. It's abnormal. So some choices to be made. at this point in time. So 1 week into this 40 milligrams of prednisone, 1 infusion of rituximab. Do we increase the oral steroids? Do we pulse this patient now and immediately go to alkylator therapy? Do we pulse and hold the course, yeah, you could tell that I did this slide because I'm dyslexic and I can even see these misspellings. It's horrendous. Do we stay the course with the rituximab and boost the steroids, or we do something else? So see what the audience says, and then see what the pros here have to say. All right, so there's some. This actually, I could see some hand wringing here. So who would like to engage on this? I mean, we have the GPA Oracle, Dr. Langford, on the stage with us, so we're going to have to come to her sooner or later. But anybody want to weigh in on just the thinking would be going on? The skin is pretty bad stuff. Let's say she didn't have this thing going on in her brain, where we really have to talk to each other, but that skin is looking horrendous. What would you be doing with that if that was the dominant thing? She just had the ear, sinus, and that skin.
I don't know that I would go to cyclophosphamide. Honestly, I think if it was the skin, to me it still looks like a neutrophilic dermatosis in a way. I would consider IVIG, but I think in this patient, when you're involving the central nervous system, you can't wait for the rituximab to kick in. You need something that is going to work fast. And we've actually done this in patients with cicatricial pemphigoid who have had upper airway involvement and have required, emergent tracheotomies where they've been given rituximab, but it wasn't enough time for it to kick in, and we're forced to start cyclophosphamide to try to get on top of this process before literally the patient dies. And I guess those are my thoughts.
Neil or Christine, you want to weigh in on this? If this was the dominant issue right now.
Right. So someone cleaned up the ulcers very nicely. So I, of course, would want to rule out a secondary infection that might be flaring the underlying process. Because this still does look somewhat PG-like, and there have been reports of PG-like ulcers in GPA, I still think that this is part of the underlying disease that's going on. But I definitely would want to make sure that there's not an infectious process that's also contributing to this worsening.
Yeah, this was always a challenge, and these kinds of patients are often in the hospital, and you got to fight with everybody, and everybody's worried that there's an infection there. I mean, this to me looks like a neutrophilic dermatosis, like severe pyoderma gangrenosum, and it needs to be treated aggressively. And I would probably hit this patient hard. Again, I'm talking about the question you asked, without any brain disease. This would be pulse steroids. This would be Imuran or Celsap, but I wouldn't hold off. I wouldn't not use cyclophosphamide. I think it depends on the rest of the story, obviously, right? But
okay, so now Carol, now adding back into the mix, this patient has pachymeningitis and this. What would this isn't your patient, is it? It is? All right, well, you know the answer, so that doesn't even count.
Well, maybe not.
Well, maybe not. This is the way that I was given this case. So hold on to the case. All right, then it goes
Well,
back.
I can say what the options would be without saying what happened.
All right, go ahead.
So, again, I think in this constellation, as far as where you have pachymeningitis, as far as which again is a CNS-threatening manifestation, and you've got this severe as far as cutaneous involvement, it would be, I think, between cyclophosphamide and rituximab. I think rituximab still is a valid choice as far as there has been data as far as, again, which Dr. Calabrese would probably tell more about as far as that shows that it does have penetration into the CNS, which would be a crucial thing. The two things I wouldn't do as far as I wouldn't use methotrexate because, again, it does not go into the CNS well. And, again, this is very severe disease. And again, I would not use a TNF inhibitor because there have been negative trials as far as in GPA, and we have at least some evidence that this is representing active GPA. So I think it would be between cyclophosphamide and rituximab as far as staying the course. Again, I think you could make a case for both. Again, if this is a younger person who is nervous about cyclophosphamide, that may be a consideration. But again, if you had someone who is very concerned as far as they've got cranial nerve involvement, cyclophosphamide would not be a wrong way to go.
Great. So these are the choices, and I'm going to just kind of fly through this. I think that there's a great sense here. This was probably underdosed with steroids now, and we have the same selection. So what was done was that the patient was pulsed, and now it's time for the second dose of rituximab, and it has to complete the course. And make the long story short, I think this patient did quite well, and I don't actually know about the eye and the brain, but the skin did extremely well. So do you recall this? Did it?
Eye and the brain did very well.
Yeah.
It took a little while, but again, the vision, synchronized, and yeah.
Just to make a comment, and Carol can respond to this, that our toughest problem with GPA is the granulomatous process, and progressive orbital disease, progressive infiltrative granulomatous stuff, and it's just not as sensitive to any of our therapies. And I had always been a cyclophosphamide pachymeningitis person, and the last handful of cases of pachymeningitis I've been primarily managing with rituximab, and I guess got to hold the course. And I can't say that I see much difference, but I do see some effects. So this is such an incredible, instructive case. All right,
So just out of curiosity, for these patients, do you typically use rituximab at the lymphoma dosing schedule? Once a week for 4 weeks?
Yeah, so the cyclophosphamide trial that it was compared against was the lymphoma regimen, 375 milligram per meter squared for 4 weeks. And that was what the FDA approved indication was. Now, the RA schedule is 1,000 milligrams times 2, which has certain advantages as far as less steroid exposure, as far as pre-treatment for the glucocorticoids. And there has been some data since the randomized trial suggesting some benefit. Now, some challenges we've seen as far as insurance approval with getting the 1,000 milligrams, particularly for Medicare, because, again, they go strictly by the FDA approvaling line. So we have used both. Again, I think in this instance, I think we used the 375 regimen.
And do you see response relatively quickly? I mean, classically, I know in dermatology, especially for autoimmune blistering diseases, I think we give rituximab, and then for it to really kick in and take effect is several months. And, when I think about this patient and what's going on in the CNS.
Yeah. Yeah, I mean, I think there is still some question as far as, and patients will ask this too, well, how rapidly is this going to take effect? And certainly part of the regimen, as far as with the combination with glucocorticoids, is that's the rapidly acting part of the regimen, and part of the reason, in addition to the broad immunosuppressive effects, why we are not able to get away from that part of the approach. But again, I think there are some effects as far as that can be more responsive. Again, I think as Dr. Calabrese says, sometimes you do have to stay the course, particularly, again, when we're using this in glomerulonephritis. I always have a bit of anxiety when we're seeing the creatinine is going up, and you're just sort of, do you hold the course, and then you'll start to see it turn the corner. But you can see that with cyclophosphamide as well.
just to make a couple comments, and there is this literature, there's a wide range of cutaneous manifestations of GPA and ANCA-associated vasculitis, as everyone here knows, and while inflammatory purpura may be the most common, PG and giant PG and malignant PG, and Tony, you've published the most extraordinary case, this Egyptian case. Does that have your name on it? The partial face transplant?
yes.
Yes,
Yeah.
right. So looking at this at 30,000 foot view, this very nice study of cutaneous manifestations of ANCA-associated vasculitides from Benjamin Terrier and the French cooperative, basically showing that when you look across the ANCA-associated vasculitides, looking at GPA, EGPA, and MPA, obviously the neutrophilic dermatoses are seen almost exclusively in the GPA patients, just like this, and that having cutaneous manifestations reproducibly compromises the relapse-free survival of virtually all of these diseases. So it's really an important part. It's a sentinel part of the management. And as the last thing I'll put in, which all of you know, is that the cutaneous manifestations can be totally independent of the systemic manifestations and no less pernicious from time to time. So this is a disease that really requires a lot of room-derm interaction.